Is Eplerenone, which will be Team A over here, versus Spironolactone right here for mortality reduction and heart failure with reduced ejection fraction. Like I said, Team A, raise your hand over there, we'll be debating for Eplerenone, and Team B will be in favor of Spironolactone right over here. All right. Can you all hear me back there, by the way? Good. So here's the case that this debate's going to revolve around. So chief complaint is I've been short of breath more than normal. EF is a 67-year-old white male, presents to the clinic for his follow-up appointment. Last hospitalized about 2 months ago with heart failure exacerbation, where he was titrated up on his furosemide and lisinopril. Over the past few months, he's experienced marked limitation of physical activity and tends to become fatigued and short of breath when he completes less than ordinary activities, like cooking, walking to the mailbox. However, he states that he is usually comfortable at rest. He has also experienced intermittent increased swelling, but is usually okay when he stays away from fast food. His weight also fluctuates, but he states he seems to be at baseline right now. So he's had heart failure for 2 years, secondary to ischemic cardiomyopathy, had an NSTEMI. And then he has osteoarthritis for 10 years and hypertension for 10 years. His mother has hypertension, father had type 2 diabetes and a stroke, and he's deceased. Denies tobacco, alcohol, or illicit drugs. And he has prescription drug insurance through Medicare Part B. These are his meds: salmeterol, succinate, 200 milligrams daily, lisinopril 20, furosemide 40 twice a day, which was increased 2 months ago, atorvastatin 40, and acetaminophen. No known drug allergies. There's his vitals. His weight is right around baseline at 88 kilos. Physical exams within normal limits. Those are his labs from today. Why don't you take a look at those? His ejection fraction is 30%. So at this time, we're considering adding an aldosterone antagonist for further morbidity and mortality reduction for his heart failure. Please evaluate his home drug regimen and select an appropriate agent for this indication. So with that, we'll get started with Team A, who's in favor of Eplerenone.
Can you hear me okay? All right, so thanks for coming. And hopefully this will be entertaining. I'm sure we'll really get at each other's throats and start yelling at each other, putting on our best lawyer hats and all that stuff. But before it gets about the nitpicky, see if I can argue better than you, let's just take our patient up here and look at what the real point of this exercise is, okay? Which is to see what we can do medically to help this guy live longer and be less sick from his heart failure, okay? Big picture, before we get into the attacks and all that stuff. And luckily, the AHA's made that pretty simple. They've laid out these guidelines, and it's pretty obvious which steps you sort of take, okay? So one of the first is you add an ACE inhibitor, the next is you add a beta blocker, and then after that, it makes it pretty clear that an aldosterone antagonist is the next step. Which brings us to our question today, which one to pick, because unfortunately they don't tell us which one, they just say an aldosterone antagonist. So that brings us to trying to figure out which one. Spironolactone versus Eplerenone. So first let's look at the class, okay? What they do as a class is they act on the mineralocorticoid receptor, which is the binding site for aldosterone. And by doing that, you decrease aldosterone's negative effects, okay? You decrease the things like cardiac fibrosis and oxidative stress and things like that, and get some of the class effect and class benefit, okay? But there are some differences, one being that spironolactone is not as specific for the receptor that we're actually trying to bind, okay? It also hits two other receptors, progesterone receptors and androgen receptors. That leads to unwanted side effects such as gynecomastia, irregular menstrual bleeding in females, and overall sexual dysfunction side effects. The other thing with spironolactone is it's got a little bit longer half-life. It also has a more complex metabolism, and it has a couple of different active metabolites, something that you don't see with morphine and Eplerenone. All right, so we know a little bit about why we add an aldosterone antagonist. Let's look at the literature now, after we know a little bit about the two specific points. Now let's look at the literature and see what it says about which one to pick, okay? And again, luckily there's three pretty good trials that we're going to be talking about today that look at these drugs. First is the RAILS trial, which came out in 1999 and looks at spironolactone. The next two are EPHESIS and EMPHASIS, which look at Eplerenone. So if you look at your sheet in front of you, you can get all the boring details about all of these studies, okay? But I'm just going to focus on the most important, which is how these match up to our patient, okay? Overall, what these did is they all reduced morbidity and mortality in symptomatic heart failure patients, okay? So across the board, it looks like it doesn't matter. You just pick one, and it's going to be the right one. But let's look closer. So what are the differences? What we see as the main difference is the RAILS trial has a lack of applicability to today's heart failure patient. Our patient, and pretty much any heart failure patient. The reason is, as I said initially, there's a few things you do in a heart failure patient. You add an ACE inhibitor, you add a beta blocker, and then you add the aldosterone antagonist. 90% of the patients in the RAILS trial, which looked at spironolactone, were not on a beta blocker. So they were not on standard heart failure therapy as we know it today. We already know there's a significant gynecomastia in these patients and all that stuff. But had they been on a beta blocker, there may have even been more side effects. More things like hyperkalemia potentially, and other things. The fact is they weren't studied in patients on therapy that you're going to have them on today. The other two trials were. And so I think if you look, you'll see that the two Eplerenone trials are a lot more applicable to today's patient because they were on, I mean, there's so many variables anyway, but one of the most important are the other medications that they're going to be on. And so those two trials are a lot more accurate as to what your patient today is going to be taking. And I think for that reason makes Eplerenone, the literature just shows that Eplerenone is more applicable to the patients that we actually have today. So in conclusion, the bottom line is we feel like Eplerenone is the better option. The side effect profile is better, the metabolism is more predictable, and most importantly, the patients and their existing drug regimens studied in the Eplerenone trials are much more representative of today's modern heart failure patients.
All right, this time we'll have Team B come up and provide their introduction.
Welcome to today's debate, colleagues. The current heart failure guidelines recommend a clinical strategy of renin-angiotensin-aldosterone system inhibition in patients with stage C heart failure with reduced ejection fraction, regardless of their NYHA class. Symptomatic control may also be indicated in these patients as well. The strategy may be accomplished through the use of ACEs, ARBs, or the newer aldosterone receptor blocker neprilysin inhibitors in conjunction with beta blockers and aldosterone antagonists. The mechanism behind the strategy hinges on the inhibition of the cardiac remodeling effects of the RAS system. Theoretically, this should arrest disease progression by slowing cardiomyopathy. Spironolactone does this broadly, while eplerenone is a more selective inhibitor, which accounts for some of the differences in side effect profile. Aldosterone antagonists, especially spironolactone, have demonstrated reduction of cardiovascular mortality in patients with heart failure with reduced ejection fraction in clinical trials. Specifically, since the RAILS trial of 1999, spironolactone has been the mainstay of therapy in HFrEF patients, advancing to stage C disease. In RAILS, spironolactone demonstrated a 30% reduction in the risk of all-cause mortality with a number needed to treat of 9. It also demonstrated a significant reduction in the secondary endpoints of cardiovascular mortality and hospitalization. These reductions were observed in patients with highly advanced symptomatic heart failure. In addition, these patients were not receiving the more comprehensive standard of care treatment that patients receive under modern guidelines, particularly beta blockers. Standard of care treatments that were used during the clinical trials for eplerenone, leading one to wonder how inflated the cardiovascular benefit of eplerenone may be given its current standard of care. Neither the emphasis nor the Ephesus trials included patients with greater than NYHA class 2 heart failure and were conducted in an era with more comprehensive standard of care therapy. Furthermore, the Ephesus trial structure raises the question of whether such cardiovascular mortality benefits are broadly applicable or may be restricted to more specific comorbidities, like end-stenting, but only if treated within specific timeframes. Our patient far more matches the patient population of the RAILS trial, rather than either Ephesus or emphasis. Spironolactone, in addition, is on the $4 generic list at Walmart. It is tier 1 on many private insurance plans, and is the preferred generic on the Alabama Medicaid preferred drug list. A 2012 meta-analysis by Chatterjee et al. Found that the cardiovascular mortality reduction of eplerenone was not superior to older, less expensive agents like spironolactone and canrenone, and in addition, eplerenone did not reduce rehospitalizations in their analysis. Spironolactone has an FDA indication for edema, which is an added benefit in patients like ours who present with such symptoms. Spironolactone also has utility in hypertension, a comorbid condition for our patient and many heart failure patients. This may be seen as additive risk reduction, as hypertension literature suggests that increasing cardiovascular risk has been associated with systolic blood pressure starting as low as 115 millimeters of mercury and increasing upward. The biggest difference in the ADR profiles, of course, is the development of gynecomastia with spironolactone versus eplerenone. But we believe the benefits of reducing cardiovascular mortality and heart failure hospitalizations far outweigh the risk of this side effect, which in clinical trials has been broadly defined to include everything from breast tenderness to visible changes in breast tissue, and is not a common cause of treatment discontinuation. The development of such symptoms is also progressive and largely reversible for as long as up to 1 year of continuous therapy. In conclusion, we believe spironolactone to be a superior agent to eplerenone in the general clinical strategy for heart failure management, as well as in our hypothesized patient case. Spironolactone has demonstrated cardiovascular mortality reduction in patients with more severe heart failure than eplerenone. It reduces rehospitalization, has less pronounced ADRs with the exception of gynecomastia, and is far more cost-effective than its competitor. For these reasons, spironolactone should be considered for initiation before eplerenone in all heart failure patients where it is clinically indicated.
All right. Can you all hear me? Can you all hear me? Hello? You guys just have to talk loud. All right, we're going to get started with Team B. We'll start with the rebuttal, and I'll ask a question for Team A to answer. You guys go first.
in Ephesus, it was found that if Eplerenone was started 3 to 14 days following a STEMI, the rates of mortality, STEMI cardiac death, and hospitalization were significantly reduced. No benefit was established following initiation 14 or greater days after a STEMI. Our patient had an event 2 years ago. So do you still believe there's a mortality benefit from administering Eplerenone at this time? And if so, how did you come to that conclusion?
So basically you're saying that would we still see a mortality benefit if it was added in our patient now? So I guess, we don't have that evidence to support that if you added it later, that you would see a mortality benefit. And if you look at the guidelines, they actually say like for an acute MI. So they're basing their recommendations based off our trial. And I guess since they don't differentiate between which aldosterone antagonists you can use, we didn't see any trials for spironolactone that had a mortality benefit in those patients. So we were kind of wondering like why you would add spironolactone in those patients. Like there's no mortality benefit for them, even if it is just acutely. And no, it would not be appropriate for our patient right now because it would have had to have been added after the acute MI when they were already at treatment doses of the ACE and the beta blocker. So it wouldn't be appropriate for our patient now, but based on Ephesus. But still, like I don't see a mortality benefit for spironolactone in these patients at all. So.
Did you just say you didn't see a mortality benefit for spironolactone at all, or Eplerenone at all?
So.
Spironolactone?
Yeah.
So, in Rails, they looked at sicker patients, which our patient, he has New York Heart Failure Class 3. He fits in that. That's what Rails was studied in. And so he fits that. And there was cause-specific and composite mortality benefit seen with spironolactone.
Post-MI though?
Well,
after acute MI?
No, it was not directly after an MI, but that was our point for this patient. We think spironolactone would be more appropriate because Eplerenone shows the mortality benefit up to 14 days after an MI, whereas our patient had one 2 years ago, and so now that time has passed, and spironolactone has proven a mortality benefit when added any time.
Oh, we have to ask a question now? Oh, okay.
We'll respond though.
Okay, respond.
The Ephesus trial also showed a similar benefit, and those patients didn't have to have heart attack.
it was a different class.
All right. We'll ask the next question. So, kind of mentioned in our intro, only 10% of the patients were on beta blocker in the Rails trial, which is not consistent with the guidelines which suggest that you should be on ACE, ARBs, and a beta blocker. An aldosterone anti should be added if the serum creatinine per gram is less than 2.5 and less than 2 in women, and if their potassium is less than 5. Now, do you think you have seen the same effect on mortality rates if the patient has been on optimal ACE, ARB, and beta blocker per ACCF AHA guidelines for heart failure in the Rails trial?
Absolutely. So in Rails, you read it, 10 to 11% of patients in both groups were on a beta blocker, and they compared mortality reduction in those 10% of patients with the 90% that weren't, and they saw no significant difference, which I find to be clinically meaningful. And this is before all the big trials of beta blockers were out. So spironolactone held its own and established its own mortality benefit before beta blockers were even thought to be beneficial.
Exactly. I'll just pass over.
But because, in our opinion, that the patient weren't on a beta blocker, there's a lot more room for them to improve. And what we're trying to say is, like, because they weren't on optimal therapy, of course you're going to see that spironolactone is going to show a lot of benefit versus in the EPHESIS and EMPhASIS trial where they were on other appropriate therapy, and then you add on Eplerenone.
So just real quick. So mechanistically, we know that those two agents act very differently on the heart and heart failure. One of them is reducing myocardial oxygen demand, et cetera. The other is working on the RAS system to prevent fibrotic activity in the heart. So beta blockers have independently been demonstrated to reduce mortality. So if you look at, if you take a patient population, and this is in our opinion, that are on two agents that have both been, or two classes of drugs that have both been theoretically demonstrating CV mortality benefit, you're going to reduce mortality to a greater degree than in a patient population as in rails, where they were not on a drug class that has also been associated independently with CV mortality reduction, if that makes sense. So spironolactone's mortality reduction was being accomplished in spite of not having the additive effects of beta blockers, if that makes sense. Is a question.
So the EMPhASIS trial focused on patients in New York Heart Association Class 2. Do you still believe that there's a clinically significant benefit to our patient, who is New York Heart Association Class 3, based on the EMPhASIS trial results? If so, how did you extrapolate this data to fit a patient population that was not studied in the trial?
Well, we didn't think that our patient fit the baseline characteristics for either of the trials, because for rails, he had to be in class 4 6 months prior to the trial enrollment, and had to be at class 3 or 4 at the time of enrollment. And there wasn't enough information to say that he fit those baseline characteristics for rails either. But if you're going to extrapolate the data, I think that the EMPhASIS would be more applicable to today's heart failure patient, because again, yours weren't on beta blockers, so how can we say that, you know, in a patient with a beta blocker and an ACE, that you can apply the results to that trial?
Also in the EMPhASIS trial, one of the inclusion criteria was that you had to be hospitalized from heart failure within the last 6 months. So just because he's not, you know, just because they weren't class 3 on the day of admission to the trial, they had been decompensated just 6 months prior. So we're still dealing with the sick patient population.
Next question.
So our next question. As most everyone knows, spironolactone is non-selective for mineralocortical receptors, and as such is often, you see side effects such as gynecomastia and breast tenderness in men, and then menstrual irregularities in women. What was the number needed to harm for gynecomastia in men in the rails trial for spironolactone, and do you think this is significant? And also, would you think this would potentially lead to a compliance issue?
So I know exactly where you got the number needed to harm of 11. That was 10% versus 1% placebo. But if you look further into rails, 6.9% of men received spironolactone 50 milligrams or less, which is how you dose spironolactone generally. So that greater number needed to harm is from high doses of spironolactone that are too high. So there's still room to titrate back down. Okay. So, also, which we mentioned in the opening, that the benefit versus risk is much greater in treating the heart failure with the spironolactone. And the actual, if you look at Supora et al., with their trial, only 4.3% experienced gynecomastia, which could be due to it being well regimented and very closely monitored. So when you start a new drug on anybody, you're going to want to closely follow up side effects. And we have found that, based off of these studies, that if you catch it before 1 year, it is reversible. And usually you see within 3 months the changes. And like he said, there is a spectrum of gynecomastia. It ranges from just tenderness to full-on like man boobs. But going back to rails, only 2% actually discontinued based off of gynecomastia. So it's a very minimal amount. And I could keep going, but you're probably gonna cut me off.
Yeah, the response rate.
Yeah.
That'll be our next question. So it might be a question. Don't say it, but that is good.
All right, questions?
All right. So since we're talking number needed, so rails had a number needed to treat of 9, while emphasis and ephesus had number needed to treats of 13 and 44 respectively. Standardize that to a year. Number needed to treats were 9 for rails, 50 for emphasis, 51 for ephesus. 50 for ephesus and 51 for emphasis, meaning significantly fewer patients need to be treated with spironolactone compared to eplerenone before benefits seen. So how do the significant differences in the number needed to treats impact your choice of therapy?
So what you're saying is the number needed to treat was a lot lower in rails compared to emphasis and ephesus, correct? So the way we looked at it anyways was our patient was on appropriate ACE, ARBs, and a beta blocker. And I hate to keep on like repeating beta blocker, beta blocker, beta blocker, but if we're following guideline therapy, and it's potentially, that's why we see a higher number needs to treat in ours, because y'all weren't on appropriate therapy, so of course that number could be a lot smaller. Greater room for improvement.
So what I'm hearing is when you add eplerenone to a beta blocker, it takes more patients before you see a benefit, whereas spironolactone by itself, there was only 9 patients before you saw a benefit.
I heard you say that our patient, like the patients are sicker in rails. And that's kind of our point, is that this patient is also a sicker patient, and the patients in emphasis and ephesus were not. And so that would apply even more.
I think what we're trying to get, our point of view, what we're trying to get across is if they're not on maximum therapy, then there's greater room for improvement. Okay, so if they had already been on their beta blocker, I mean, if you've already made them better to some degree because of that maximum therapy, then it's going to be harder for you. You're going to have to treat more patients with the add-on drug to continue to see improvement.
I can understand. Yeah, I see where like what you're
Oh, I'm sorry, I almost dropped the mic. All right, so our next.
Not yet.
I didn't realize what I was saying. All right, pun intended, not intended. All right, so according to the NOHAR 2008, higher prevalence of breast cancer in men has been associated with ethnicity such as being white, that's an intermediate risk, age with increasing age, and obesity. Now understand that breast cancer in males are rare, but it's still something to be concerned about. Our patient BMI is currently 28, and he has gained weight and is considered overweight and is tiptoeing towards obese. He is also 67 years old. Now, let's just say that he comes into the clinic with gynecomastia. How are you going to convince the patient and yourself, beyond the shadow of a doubt, that this is a benign problem that's associated with gynecomastia versus cancer?
So the question is, when he started presenting with gynecomastia once spironolactone was initiated, how would you differentiate between if this was a malignancy versus just a drug side effect?
Yeah, how would you clinically look at what comes back?
Well, if you're thinking, because it's hypertrophic, like tissue, sure, okay.
He comes back in nervous.
Okay, well, we can do an ultrasound, which is, he doesn't care, it'll cover it, it's good. We can do that, but also, we know that there is a side effect, but there's also a known side effect of, we're talking about this patient, right? Or any ACE inhibitors, calcium channel blockers, digoxin, all those also have a side effect of gynecomastia. So we can't extrapolate or totally say that it is directly from spironolactone. Okay, but he's also, aging is a common reason for men to start developing breasts as well. It's okay, and she wants to butt in too, but so yeah, you would definitely, if he starts having hypertrophy of the breast, you would automatically order an ultrasound. But then if that comes back as a benign process, of course, then you can discontinue spironolactone and change to Eplerenone if the patient wishes, as long as it is a benign process. Okay, I actually found two articles, Figueroa et al. From 2013 and McKenzie et al. From 2017. Both show that spironolactone was not associated with increased cancer risk. Actually, spironolactone reduced the risk of prostate cancer. And I think that in our patient, being the age he is, so beneficial. And these trials were actually pretty large, 2.3 million for the Figueroa et al. Trial, 74,000 for the McKenzie et al. Trial.
So we're going to ask one more question for each side, and you get to respond after they ask their question.
But we weren't asking about cancer. Yeah, we know that's not our good cause.
He's going to die of heart failure way before prostate cancer. But
Agreed.
But no, what we're saying, yes. So old age, all of those things can increase gynecomastia. Is the gynecomastia, when you add this agent, is it going to cloud your picture, your clinical decision making? Are you going to have to order more tests? Is it going to potentially increase the cost of things? Because not necessarily it's going to cause cancer, but it's going to cause him to come back with this issue that has to be evaluated. More office visits, more imaging, more downstream cost. That's
Yeah.
So, serious hyperkalemia was defined in both Rails and the Ephesus trial as a potassium of 6 or greater. In Ephesus, Eplerenone showed a statistically significant difference in serious hyperkalemia, greater than 6, when compared to placebo. In the Rails trial, spironolactone was not shown to cause a statistically significant difference in serious hyperkalemia when compared to placebo. How do you plan on managing the interaction between eplerenone and lisinopril, given that the patient's potassium is already 4.7? Eplerenone is associated with more severe hyperkalemia when comparing the trials Ephesus, Emphasis, and Rails.
So his potassium level is still within the range of like being able to add an aldosterone antagonist. And there was actually a trial that was published after the Rails trial that studied the rates of prescription use of spironolactone and compared that to the rates of hyperkalemia associated death and hyperkalemia associated hospitalizations. And you can see from the charts in the trial that as soon as the rates of prescriptions for spironolactone went up on patients that were already on an ACE inhibitor, so did the rate of hyperkalemia-associated death and hospitalizations, and it almost went up threefold. So when you're actually applying this to real patients versus like the continual monitoring in that Rails trial, I think you actually see more hyperkalemia than the trial shows for Rails. And we would argue that because the because the half-life is different for spironolactone versus eplerenone, that you actually are in higher risk for hyperkalemia for spironolactone because it hangs around longer than eplerenone might.
Were you talking about the Gerlach et al. Article? The one that was making the correlation between the publication of Rails and then the increase in spironolactone? Okay, so that's what it was saying, is that Rails was published, and then after it was published, there was an increase in spironolactone use, and they were studying the increased incidence of hyperkalemia in heart failure patients. So information in this trial was collected from a database where the accuracy of diagnosis codes was uncertain. They weren't even 100% sure that these patients had heart failure. They also were not sure what all medications these patients were on. They didn't have any baseline labs, and they didn't know their other diagnoses that could have caused hyperkalemia, like CKD. The study also did not clarify their definition of a hyperkalemia-associated death, which could mean anything. They could have just happened to have high potassium at the moment that they died, which is a known cause. Hyperkalemia, I mean, potassium does increase naturally at the time of death and after death. The study itself stated that the most likely reason for hyperkalemia during that trial was due to interactions between spironolactone and ACE inhibitors that was accentuated by other medications or coexisting conditions, which they did not list. The study overall was also observational, which means that it cannot be proven, and it can only report this trend.
Last question.
So our patient is currently considered NYHA class 3, as y'all kept on saying. Like the Rails trial, our ultimate goal is to reduce the symptom from a class 3 to a class 2. The guideline states that you can add an aldosterone antag to the patient of NYHA class 2. Do you think you can apply the results of your trial to our patient if he becomes a class 2?
So to become class 2, his symptoms need to get better. And in Rails, they actually saw that 41% of patients saw improvement in heart failure symptoms going from class 3 to class 2. So he would get to that class 2 that you want him to be at with spironolactone.
But now he's at class 2 at baseline, and you're studying sicker patients that had to be in class 4 previously and then class 3 or 4. So again, like, I guess, can you apply your results? Can you apply like your results from the Rails trial to milder patients?
When you're looking at the whole guidelines, it's talking about symptomatic patients, which could be 2 through. So in this question, we are talking about the guidelines, addressing the guidelines, I think, as a whole, which also includes class 2.
I mean, I was just going to make the point that spironolactone also has an FDA indication for edema just by itself. So we know that it has effects in reducing edema, which is one of the primary contributors to symptoms of heart failure. Fluid retention, pulmonary edema, etc. So I think we can extrapolate with relative confidence that even if the symptomatic burden may reduce in the patient, that doesn't necessarily mean that the drug is no longer effective in reducing symptomology. But the problem with symptomology in general in heart failure is you don't usually see more than a drop of 1 class in symptomology once you start getting up to like 3 or 4. So I mean, it's going to be, and because of the way that the disease progresses, I think that it's more of a question of can we prevent it from becoming worse than do we want to reduce them and get them to stay there, because it's going to be more likely that we're able to stabilize the patient than improve their symptoms until it goes away, which rarely happens. That's what I'm trying to say. I am just rambling right now.
And only from a portion of the debates. We'll go ahead and have Team A come up with provide their closing statements. Oh, yeah. Oh yeah, you get 5 minutes, sorry. They get a 5-minute break before they, to prepare their closing arguments.
All right, so for Eplerenone, our conclusion is that we believe there are several factors that must be analyzed to determine the best choice of aldosterone antagonist for the treatment of our patient's heart failure with reduced ejection fraction. So some important factors to consider are appropriate use in clinical trials, the side effect and pharmacokinetic profile, cost, and even drug interaction profile. So, as we stated in the introduction, and it was discussed through the debate, the RAILS trial, it did not have a majority of its patients taking a beta blocker. So, due to this, the exact benefit that a patient will receive by adding a spironolactone to guideline-directed therapy cannot be determined in current heart failure patients. So, in the assigned case, heart failure patients, in the same case, the patient has heart failure and started taking guideline-directed therapy with an ACE inhibitor and beta blocker. In addition, the patient developed heart failure secondary to an NSD. So, as we mentioned in the Ephesus trial, Eplerenone can reduce morbidity and mortality in patients with an MI and heart failure with left ventricular dysfunction. Due to this and some controversy surrounding the use of spironolactone in RAILS, we feel that Eplerenone is the best choice for these patients in ischemic provoked heart failure. Also, we believe there's differences in these agents, and we believe these differences favor the use of Eplerenone. First, since we're talking about Eplerenone is more selective, so it's less prone to some of the anti-androgenic effects you see with spironolactone. So menstrual irregularities, sexual dysfunction in men are important adverse effects. It can be detrimental to the adherence of patients to this agent. Gynecomastia is a serious adverse effect and has been shown in clinical trials to occur significantly more in spironolactone than Eplerenone. While not clinically proven in randomized control trials, we do believe that the risk of breast cancer in this patient should be considered in the choice between these agents due to 3 factors. 1, spironolactone's black box warning of being tumorigenic in animal studies. 2, the patient's BMI trending towards obese. And 3, the risk of gynecomastia in spironolactone. So all of these factors associated with an increased risk of breast cancer with the use of spironolactone. And even if the breast cancer risk is minimal, it's likely to distress our patient and lead to a costly evaluation. Another adverse effect of these agents, hyperkalemia, as discussed in the debate, has been a common concern in clinical trials. So this could have resulted from elevations of potassium levels due to the use of a beta blocker and an ACE inhibitor in patients before the addition of Eplerenone. As previously discussed, the safety of Eplerenone, as indicated by RAILS, may not be as favorable as originally perceived. Also, when we examine the PK profile, spironolactone, longer half-life, and active metabolites can lead to drug accumulation and possibly increase hyperkalemia. A disadvantage they brought up in the debate for Eplerenone was cost. So even though individual tablets of spironolactone are cheaper than Eplerenone, we feel that the adverse effect profile could lead to complications and additional medical expenses to patients taking spironolactone. So due to this, a clear advantage for spironolactone over Eplerenone in this area is questionable. In conclusion, we believe that based on the patient's specific disease states, the advantageous side effect and kinetic profile of Eplerenone, and the lack of potential drug interactions, Eplerenone should be the appropriate choice of aldosterone antagonist in this patient. And we would like to place emphasis on the fact that Eplerenone is the correct choice for our patient, and state that if you don't agree, you could be off the rails.
Nice.
All right, Team B will now provide their closing argument.
In this game of O's, spironolactone, eplerenone, you either win or you die, right? And in terms of the beta blocker question, at first I had thought it was a question of optics, but what we're really looking at is mortality, and I think mortality is a pretty black and white issue. It's either you are going to live or you are going to die. And basically what we've seen here is that there is benefit for spironolactone over eplerenone in terms of reducing relative risk from death of all causes, all cardiac hospitalizations, and worsening heart failure hospitalizations. Thus far, there have been no studies for eplerenone in heart failure class improvement. Additionally, there have been multiple times when spironolactone has been attacked on the front of metabolism. Eplerenone, I would want you guys to know, is metabolized by 384, and that's one of the major CYP, it's a major CYP interaction, and you could have lots of drug interactions there, like amiodarone and those sorts of drugs. Now, when we look at the benefits of spironolactone, what we could also see here too is that the FDA has a clear indication for edema improvement for spironolactone as opposed to eplerenone that's missing. And then in the Pathway 2 trial, I'd like to bring that up, spironolactone has been proven to also give a greater benefit in blood pressure reduction overall. And in terms of heart failure, we can think about how it's beneficial as well. It reduces remodeling and has a greater impact on mortality reduction. Finally, I'd like to go and talk about the side effect profile that was brought up for spironolactone. It's gynecomastia, and that seems to be the elephant in the room here. It's so we have 10% for spironolactone, 1% in placebo, and we see that this is an indication for where pharmacists and physicians can definitely get involved in patient care in vigilant monitoring. And as was mentioned, gynecomastia is not something that just suddenly happens. It's a gradual and reversible process whose severity exists on a spectrum. More importantly, recall that only 2% of patients decline continuation in the RAILS trial due to adverse reactions. And so under direct supervision, patients can experience the benefits that spironolactone has. Last, but certainly not least, cost will definitely play a huge portion in whether or not your patient will take this drug. And here we can see that spironolactone is universally accepted on most preferred drug lists, and it's on $4 per month list too. And so it's not gray here. There is a substantial difference in cost between eplerenone and spironolactone. And to go and put this into perspective, each eplerenone tablet costs approximately 10 times that of spironolactone for a comparable dose. And so when you take all of these factors into consideration, we believe that spironolactone still warrants its place on the Game of Thrones.
All right. We'll now take questions.
any information about proteinuria with a more expensive drug. That would be one other point I'd bring out. Spironolactone does help. It's one of the few diuretics that actually helps with proteinuria. And I'm not sure about the argument of breast cancer. I haven't seen any studies. Understand. There are lots of drugs that cause gynecomastia. Over-the-counter Tagamet, particularly, is very prone to cause gynecomastia. It is reducible, and if they stop it early enough. If I have a transgender patient, I might pick spironolactone over. I'm just kidding a little bit. And then the cost issue, you have to understand most of these patients are going to be taking, just for their heart failure, at least 3 or 4 drugs. And then on top of that, their lipid agent. And then most of them are probably going to be insulin resistant. And so drugs do tend to mount up. And the drug interaction pathways, you have to be mindful of. You can actually use them in your favor. Sometimes you can do piggy bank drugs at the same pathway. This would go with lower doses. And anyway, I usually go cheap first, side effects, then you adjust for that. With the new potassium binding agents, a lot of the patients that used to fail these drugs will no longer fail them because we will start using the potassium binding agents. We had to quit using Kexley because of bowel ischemia and other things. But the game is changing with potassium binders. So anyway, cheap first, side effects adjust, and eventually maybe y'all do the same price. What I would like the drug company to have done is actually do a head-to-head with their competitor. It is unfortunately a gamble, and several times in the past when drug companies have done that, they've usually lost. So that's why it's rare to see a head-to-head.
Y'all have any responses or comments?
I just wanted to comment a little bit about the cancer thing. I guess the question, I didn't phrase the question as well as I should have, and I do apologize for that, whoever misunderstood, but the thing we were trying to get at is if the patient come in with gynecomastia and they're, like, he's around the age where breast cancer is normally diagnosed. I found like the median age is around 68-ish. So if he came in concerned about if he developed gynecomastia, we were just trying to aim at the point, well, it's going to be more cost for the patient to undergo diagnostics to determine if it's due to spironolactone or was it due to if he really did have breast cancer and it just now started to show up or something like that.
Yeah, usually when most men develop breast cancer, it's an isolated lesion in one breast. It's not bilateral, so the presentation is different, and also unfortunately the treatment is a little bit different.
But he may not know that. They'll still come to your office.
That's what your mouth is for. You're supposed to reassure him.
After you take a
And by the way, I don't think I've seen you dressed up like this. I thought you were a drug rep. But at the same time, again, that's why it's so important up front to tell patients what the side effects of this drug are, and I'm going cheap for you. And if you start to develop those side effects, then please let me know so we can start adjusting. I think the only other thing I want the residents to know is that when you start some of these drugs, you do not say, I'll see you in 3 months, because the hyperkalemia, when it occurs actually pretty quickly. So you need to be more vigilant about making sure they follow back up. And also, since the patients are tired of taking all these drugs, it's not unusual for them to stop their medication. And so making sure that you have a good talking relationship, have them come back repetitively for the first year until they're totally stable, and then intermittently make sure that you follow up and check them again to make sure they're still taking the medication.
Yeah, for spironolactone, the labeling actually recommends to monitor potassium the first day, at day 3, at day 7, at 30 days, and then at 3 months, and then every 3 to 6 months thereafter. So it's really vigilant monitoring, like Dr. Sarles was saying.
They want to address the proteinuria question. The proteinuria question, did y'all have something to say?
It was for spironolactone. It's not any evidence pertaining to Eplerenone, so I don't know if I really need to talk about it unless they have something to say.
Go ahead.
No, go ahead.
Tell us.
So we were just going to talk about some of those side effects that they talked about spironolactone having active metabolites and causing these other effects in the body. Sometimes can be a good thing because spironolactone can be used to reduce proteinuria by 33% in patients with diabetes and hypertension and albuminuria. So that can be a really good thing for these patients who do have often insulin resistance because it goes hand in hand with heart failure. So that is another plus to think about with spironolactone.
So there's one trial that we looked at that actually showed a bump in the spironolactone group from an A1C of 5.6 to 5.8. So would you be concerned that it's going to lead more, push forward the progression of the diabetes and maybe even progression of the proteinuria? I was asking Dr. Sarles.
No, I can answer for him.
I would have already changed the beta blocker the patient was on to worry about insulin resistance because they're on beta blocker. So if you're gonna throw stones, make sure that you are throwing the right stone all the time. Anyway, so insulin resistance, unfortunately, the statins all do it. So you can try to pick the one that's least likely to cause it. But a lot of times that may not get them to go, so they're more likely to die their event. So you try to get them to go, and so you pick the best horse to get on for that. But realizing you may be causing some other problem. But statistically, they're more likely to die of their complications of the disease than the disease that you may be aggravating with the use of the drug.
So that study by Yamaji showed that there was the increase in baseline A1C from 5.61 to 5.8, which is a difference of less than 0.2% in A1C. So it's not significant. Well, it was significantly different, but a 0.12% difference really isn't going to make a huge difference in a patient. It's very manageable. Aside from that fact, and our patient does not currently have diabetes, there's still more proof that spironolactone is safe and recommended in diabetic patients. The American Diabetes Association is associated with a journal called Diabetes Care, which has put out studies showing the safety of spironolactone in patients with diabetes, nephropathy, and hypertension who are on recommended doses, max doses of ACEs and ARBs. And albuminuria was reduced by 33% during those trials, and spironolactone is recommended in diabetic patients. So I don't think it's really a concern. We don't really need to be concerned about spironolactone causing diabetes when it's actually a drug that's recommended to be used in diabetic patients.
Any other questions from the audience?
This is just a specific question about spironolactone. Doesn't even have anything to do with this, but in your literature review, I've had a couple of people come in that their dermatologist will put them on it for hair growth. So what's the new stuff out there about that?
Oh, for like male.
Well, specifically, I have a female patient.
Oh, for
Hirsutism.
So she's losing hair?
Thinning of hair.
Well, I know it's indicated due to its anti-androgenic effects. Only if it is the male pattern baldness, meaning that there's too much testosterone, correct? Right. Yes. So I don't know the dosages off the top of my head, but what were you asking?
Have you saw anything to support that? So it's really only male pattern, like even like.
For that,
She's got thinning of her
entire head. Yeah, usually I think it's more, the male pattern is more on the top, right? Like, meaning that they have excess testosterone for, like Dr. Pope, yeah. So I did read that, yes, it's actually indicated for that. And then
But yeah, I don't know what else to add to that.
The only other caution is if you're using spironolactone in women, make sure they're not on gas at the same time. Because hyperkalemia can get pretty significant.
It's just using a side effect. Yeah, it's using a side effect for therapeutic use, basically.
Yeah, and the anti-androgen effect can also help with acne too.
Yep.
Some females use that.
Yeah, the dermatologists,
Yeah.
they put teenagers.
Yeah. And they gain weight sometimes from that.
Oh, yeah.
Eplerenone.
Just talk about more of the drug interactions with and metabolism of eplerenone. A little bit more than
Well, you're not supposed to use it with strong 3A4 inhibitors. But when we kind of looked at those, it seems like there was other like medications in the class that you could use that weren't strong 3A4 inhibitors, like if you had to use an antifungal or things like that, that you could get around it with.
Yeah, and like Dr. Shaw said, I think all the time we're using variations of that, like diltiazem and Lipitor. So you just have to be, it's just something you have to be aware of and titrate your doses of the different drugs accordingly.
Is there anything about Eplerenone and pregnancy?
Take class.
I know it's not been data for
eplerenone in pregnancy.
Next class,
You're not
I don't think so.
I can follow up that question. I'm pretty sure it's a class B though.
I was just wondering, because I think the
Really?
reason spironolactone is not very good is because of androgen.
Yes.
Yeah. And anti-androgen effects.
I'd be surprised if there was a
What did
B
y'all say?
from something. It is B?
Yeah, Eplerenone is class B.
There's limited data for spironolactone.
Any other questions? So just kind of like we always end the debates, putting away like the research and everything you've done and thinking about the other team's argument, looking at all that, what drug would you guys have chosen? Or would it have changed or be non-preferential?
Yeah, just pass it around. I mean, I would have chosen spironolactone because I guess my mental framework is kind of different, similar to what Dr. Stars was talking about. Is just, if you can reap a benefit with a cheaper version first, and you have a patient that doesn't present with the ADRs, then you've saved a lot of money for the system. You saved a lot of money for the patient, so or the practice potentially as well. So, but you guys, I don't know. You guys made a lot of good points about Pokemon. So.
I would have chosen spironolactone as well. Spironolactone, for the same reasons.
Yeah, same spironolactone.
Same as well, and I think that what I really want to stress is that eplerenone is a really great option. It's just that right now, in its nascent form, we don't have enough data, like in terms of its efficacy, in terms of cost benefit for its supremacy over choosing spironolactone there. And so I think that that's where I would fall that as of right now, I would definitely go with spironolactone because of that cost issue.
And so before we started the debate, I was really kind of mad. I was kind of want to be on. But I did, you see a lot about, monitoring, that kind of thing. So gynecomastia arises or any other issues, you can switch. But I did find that, like over time as eplerenone becomes cheaper, that there was a lot of the stuff in the literature that they based, the use of spironolactone on eplerenone and vice versa. So, but Yeah, to start out with, I would probably start with Spironolactone in this patient.
I will have to go with Eplerenone. The reason why I said that, I'm already overweight as is, so gynecomastia on me will just look pretty bad.
I think I would choose Eplerenone also, just because, like, when I was actually looking at the literature, I was really surprised that we were basing our guidelines off of like a really old trial, like from 1999, that is not with current like therapy. So I guess when looking at it, I guess Eplerenone to me still has more evidence, like current evidence for mortality benefit.
I thought so too. When you look at the actual AHA guidelines, I think it almost seemed like they sort of, in a way, got them from the results of the Eplerenone trials. But in reality, you're going to use what you're familiar with, and I've never seen anybody use Eplerenone. And so I mean, you know, in a residency program, and really when you go to different hospitals and things, I mean, every place you're at kind of has different things that they do. And so from around here, you see this Spironolactone a lot more, and of course the cost. But I really did think the evidence for the Eplerenone was interesting. And when the cost comes down, you may see a shift.
Yeah, that's a good point.
Says the Pfizer salesman.
No, and I think you guys brought it up, and I think you have to keep in mind that the Rails trial was completed before the era of beta blockers. Like Merit was ongoing in the late 90s at that point, so that's why you see, and I think you guys made a good point about there's more room for improvement when you're not on standard medical therapy that's already reducing mortality. So it's all kind of an additive benefit, and ultimately you're just going to do what the patient can tolerate, because the amount of people I've seen be able to tolerate all three of those agents at max doses is few and far between. Did you?
I just thought I would tell you real quick about my particular patient. He had been on all the drug classes for hypertension, still had sky-high pressures. He was a rocket scientist, kept good numbers at home, always had high blood pressures. Ultimately went into the ER, he didn't have an MI, but they put 2 stents in him. And he'd been on these medicines for several years, more than 10, and they just adjusted a little bit. And he noticed one day a lump in one of his breasts that occurred like over 2 months. So I worked him up. He's about 62. I did the ultrasound and ultimately made him feel better by doing a biopsy. It was benign. And then we tried him off of Spironolactone for a little while, but he had so much edema he wanted to get back on. And as long as he knew it was benign, he was good with that. So it's just interesting that I had this patient about a year ago.
I just wanted to make the point. I think y'all did a really good job of talking about guidelines versus all of the evidence, because we really push you guys to learn evidence-based guidelines and follow those. And I think that's fairly easy to do because you have an algorithm, put them on this drug and this dose. But sometimes when you actually look at the data, it's not as clear. And y'all did a really good job, I thought, pointing that out, you know, the timeline of that Rails trial and then the guidelines and some other evidence. So good job with that.
One other point too, guidelines
take a long time to change. If you find yourself practicing based on guidelines only, you will be behind the game most of your career. You should be constantly evolving and changing and staying in front of the guidelines, so when the guidelines actually come out, you've been there, done that, on to the next one. So I think it's, from a teaching standpoint, it's wonderful to learn guidelines, but guidelines are usually set. Sometimes guidelines change and they're wrong when they change. And so if you don't keep up with literature and realize that either for political reasons or for bad choices, someone changed the guidelines, you will do your patients a disfavor by always chasing the guidelines. So use them for what they're intended for, which is to bring all of us up to speed. But I want you to be in front of the group.
All right, anything else? All right, well, thank you teams for participating. Let's give them